the most important. Doing an X-ray is something which is into practice. What test do we have? We have a Mantu which is there, but again, a lot of people still use 10 TUs, 5 TUs. We understand that the tuberculin which is available is non-standardized. Hardly 1 or 2 TU is available. The cutaneous TB test is still not available. That is what I understand. IGRAs are quite costly. So 5 family members testing, all of them with an IGRA, um, 2,000, 3,000 is the approximate cost, is not very feasible in all sectors. Test them, treat them. You have 6H, which is most commonly available. Do follow them up for one symptoms, because some of them can develop a disease even on an LTBI treatment, and also look at adverse drug reactions. So TB preventive treatment is one of the key interventions which is recommended by WHO to achieve the NTB strategy targets. The benefits have been extended to all household contacts of pulmonary TB patients. So that's important. We, invariably every week would see a patient where someone in the family had tuberculosis, and TB preventive treatment was not offered, and that person develops a disease. So I think that is a very important thing which everyone should understand, that it is now not restricted to less than 6 years of age. It is now expanded to all household contacts. We have shorter regimes which are underway, but in clinical practice, 6H is something which we offer. So thank you very much, and I'll hand over to Dr.
Thank you, sir. Thank you so much. I think we will straight away start with our next presentation. I will request Professor Kabra here to give his presentation on where do we stand as of now as a country when it comes to NTB 2025. Professor Kabra, please.
Respected chairpersons, moderator, and friends, the topic assigned to me is where do we stand as far as NTB 25 is concerned. So I'll be talking about what are the targets and what are our achievements and reasons for not able to achieve the targets by publication in India and abroad, and personal experiences, and then what is the way forward. So let us see. The WHO NTB strategy 2025 milestones were that the incidence rate, we need to reduce it by 50% from the baseline of 2015. And what is our achievement in the world? 8.7% reduction. Instead of 50%, only 8.7%. And number of TB deaths, our target was that it should be 75% reduction, while we have achieved only 19%. And percentage of people with HB facing catastrophic total cost, that is, the people are spending a lot of money and going below the poverty line, that should be 0, suggesting that all the people should get the anti-TB drugs free, but still half of them are getting, half of them are not getting. So there is a significant gap between the target of incidence, deaths, and percentage of people with the TB facing catastrophic total cost. Then let us see that in 2018, UN high-level meeting on TB treatment targets were that TB treatment for all should be started in 40 million patients all over the world, and it was started in 34 million. We could achieve up to 84%. And treatment of children, it was, so target set was 3.5 million, but we achieved only 2.5 million, around 71% of the total burden. And MDR TB treatment for all age group, target was 1.5 million, and between 2018 to 22, and we achieved up to 55%. And MDR TB treatment in children, as Tanu has already pointed out, it is very dismal performance as far as children is concerned due to various reasons, and only 10% the target was achieved. Then another one was TPT, as Ankit already pointed out, that there are certain problems in it, and the target was like by between 2018 to 2022, 39 million targeted 39 million, while we achieved only 15.5, that is 52%, less than around 50%. But if you see the people living with HIV, it was more than 100. It was 100%. And the problem is if a child is household contact below 5 years, we could achieve up to 55%, and contact of more than 5 years, it was only 10%. So we performed better as far as below 5 years of age is concerned, but we were not so good in above 5 years of age. Then the funding target, that is that the UN body suggested that there should be a help of 13 billion US dollar in 22, but it was only 5.8 billion, that is less than 50%. And the same thing is for the TB research. Instead of 2 billion, only 1 billion was available, and that was 50%. So this is for the world. Say case notification of TB, newly diagnosed with TB in India. All these reports are from the Global TB report and India TB report of 2023. And you can see here that from 2015 onwards, there was constant increase in the reporting notification. But in 2020, there was a steep decline, and subsequently, good thing is that we could achieve back in 2022 more than what was expected in 2019, 2020. And you can see that what the COVID has created a trouble, that this is the mortality, and you can see there is an increase in the COVID-related death. This is for all age group. COVID-related TB, more TB deaths. So definitely there is a gap between the target and our achievement. Then what are the reasons? So I have selected 3 papers recently published in which clinical TB division people were also part of this study. And you can say one is situation analysis for TPT. And this was a mixed method approach to conduct a situational analysis of initial phase of TPT implementation among household contacts of pulmonary TB patients in the 3 districts of Delhi. And results were that organizational structures and planning were established. This was good thing. But implementation of PPT was suboptimal, with issues in the drug availability, procurement, budget, human resources, and training. Awareness and motivation and sorter regime, telephonic assessment, and collaboration with NGO emerged as we may be able to perform more enablers. Barriers were apprehension about taking PPT, erratic drug supply, long duration of treatment, side effects, overburden, large population, and a possibility of INH resistance in the range of 10 to 14%, data entry issues, and private providers' reluctance emerged as barriers. So conclusion was, while progress has been made in TPT implementation, there is a room for improvement and refinement across various domains. I selected this paper because it was published recently, only last month, and TPT, as Dr. Ankit pointed out, is one of the mainstay of one of the main tool for control of TB. Then you can see here that the barriers were multitasking, lack of training in the TPT, supervision in monitoring challenges, and personal conviction regarding INH resistance. And the other problems related to the program was drug supply and procurement challenges, down time of the NICSHA ID and NICSHA work program, human resource shortage, data entry and system issues, large population to cater, lack of convergence between the sectors, prioritization of the other services, and private providers' reluctance. It is again summarizing that what are the barriers and limiting factor for TPP. Then another one is this patient's unmet need of a resistant tuberculosis. And this was to identify, this was study carried out in Pune and published last year to identify and describe the unmet needs of patients with multi-drug resistant TB. And it was interview of 128 patients. Barriers were delays in diagnosis. As we can understand that a patient comes to a physician, he makes suspect and makes a diagnosis. He sends the sample, sometimes may have to get it from the private laboratories, lack of counseling, late referral to the NTEP, and unwarranted expenditure. Unwarranted is that the patient has to spend out of pocket because some of the time these tests are not available easily. NTP care centers providers dismissal of the symptoms, non-courteous behavior, lack of hygiene in the referral centers, or stay with the other patients, and lack of support for the psychological and psychiatric problems. So conclusions were attention to patients' several unmet needs can be improved in MDR TB care. These include educating private providers about MDR TB risk and available rapid molecular assays. At the RNTCP and TEP, training health workers to build rapport with the patients, maintaining hygienic environment with adequate isolation of the participants with MDR from other serious cases. Referral of the patients with the psychiatric symptoms to mental health specialists and monitoring drug shortages. Then, is there a scope or existing facility can be utilized optimally? So a partnership under NTEP was established to strengthen the TB laboratories, and 61 culture and DST laboratories were added, and this has a capacity of 200,000 liquid culture and 170,000 molecular DST annually. The laboratory networks were operating at 69% of efficiency, and there is a possibility that there may be enhancement of these services, like liquid cultures can be 450,000 and first line DST 180,000. As all of us are aware, these tests are not available easily. So additional capacity is there. It needs that there should be will for the managers to increase it. So personal experience is the technical aspect, the technical report guideline is excellent. It includes all these things. But for pediatric patients, my personal feeling is that MGIT culture should be carried out in all the patients because the samples are very precious. And diagnostics or easily available samples should be accelerated, like a stool sample, urine sample, other body samples. And it is mainly the operational aspects. Lack of communication with dose center. Dose center people, they are whatever is their experience or whatever is their qualification, they just remain a supplier of the drug. Erratic supply, diagnostic as well as drugs. Lack of system for recording and reporting side effects. No counselor for the TB patients. It is very important that these patients require a good counseling so that the targets can be achieved. Healthcare facilities are not child friendly. As in the public sector, fixed days, it may be say my OPD days are Wednesdays and Fridays. If patient gets some problem on other days, they are not being entertained. Poor OPDs, IPDs, and provision for acute care is not there. Whom to contact if someone is having a problem? Changing daily, there is some change of the healthcare workers, doctors, residents, and continue the same treatment remains. This is a typical of a public sector. Even in the private sector, there is no responsive people who can take care of their problems. As we do some treatment for the fancy diseases, but for a common illness like TB, we do not have a psychological support, we do not have a daily or some acute support. What is the way forward? First and foremost is we accept the suboptimal performance and review the barriers. Revise and restart working on these to achieve targets. Strengthen the feedback from people working with the patients and in the field rather than people making the strategy without knowing the field problems. Immediate action on the feedback received and communicate action taken to stakeholder, irrespective position of the stakeholder. If it is some problem is raised by a nurse or a field worker, it should be taken seriously. Active actions to reduce procedural delays, make all stakeholders partner in NTEP, and we work towards achieving our targets. So this is UN body has revised the targets now. They have fixed 2027 as the target to reduce the incidence and all these achievements. So where do we stand? To summarize, I am very optimistic because highest level of our executive, that is Prime Minister, heads on commitments, and there is a significant achievements as far as pediatric TB is concerned, but there is a gap between target and achievements. And as I am witness to actually seeing this pediatric TB for last 3 decades, there are significant achievements, but gap still remains, and there is a scope for improvement. Reasons for underachievement is technical aspect. It is the nature of illness, no effective vaccination, and difficulty in diagnostics in children. Operational aspects, maintenance of supply chain, because this is mainly our guidelines prepared by the Central TB Division is excellent, but operational aspects are lacking, and there is a maintenance of supply chain, poor communication between the care providers and managers, less funding, and to some extent COVID-19 pandemic was also responsible for underachievement. Way forward is accept our weakness, revise our targets and strategies, make all stakeholders partner, establish two-way communication between the care providers and administrators, and increase funding for care and research. Thank you very much.
Thank you so much, sir. As always, your presentations are a good source of learning how to be crisp and finish on time. So we have a list of questions lined up with us. I think first I'll request Dr. Tanu Singhal. There is a question that when you suspect primary versus secondary drug resistance, how do you approach such a patient? Based on examination, radiology, what will be the pointers which will tell you that this is primary or secondary? Is there anything there, or how should you approach?
No, so secondary drug resistance means that this child has already been taking treatment for TB and then has treatment failure. So that would be a pointer that it could be secondary drug resistance. Whereas primary drug resistance, you would think in a child who's non-adolescent or whatever be the age, who has come with TB for the first time, has no history of exposure to TB treatment earlier. And it is important because if the child has already, if you're diagnosing secondary drug resistance, that means the child has already been exposed to many drugs before, and therefore our choice of regime may be different. But otherwise, it's history only which will tell you whether it is primary or secondary.
Perfect. So history tells you whether it is primary, but on examination, on radiology, there are no pointers which can differentiate between these two. That was the question. Secondly, if what is the youngest age at which you can give bedaquiline? And in newborns, if suppose you have to give, what will be the alternatives if you cannot give it?
So, as per the government, bedaquiline can be given above the age of 5 years. But in Mumbai, we have been giving it off-label in children below the age of 1 year. I don't have experience with giving it to a newborn. But I guess in a very young baby, you would replace bedaquiline with an aminoglycoside. That would be the way to go. So you would use even the program says that all the regimes where you have bedaquiline, if the age is below 5 and if bedaquiline cannot be given, you replace it with an aminoglycoside or another group C drug.
Perfect. There's a question that if you are treating a patient with a pleural TB, when do you expect response, clinical response? What would be clinical response to you, and when would you start working for drug-resistant TB in such patients?
So this is a big dilemma because pleural TB, it is difficult to establish the the microbiologic diagnosis because most of the times the pleural fluid NAT is negative. So you start treatment empirically for first line, and by 4 weeks, you should start seeing a response in the form of resolution of the fever, the chest pain, and weight gain. I don't think you can look at radiological response to guide, to differentiate between response and non-response because the effusion may take a long time to go away.
Thank
But
you. So
yes,
which means, yes.
But yes, by 4 weeks, if you're not seeing a clinical response in terms of resolution of fever and starting of weight gain, you would start working up the patient. And in such a patient, because you had done a pleural tap initially and your expert was negative, you would probably try and get another sample with a higher yield, like you would probably do a pleural biopsy to make a diagnosis.
So we do not have to just chase the radiological shadows, look at the patient holistically and completely. What about this test TB Sure, which is being marketed by some private labs? How sure are we on this TB Sure?
I please let the other panelists enlighten on this, but I don't know about this test. And one more thing, which I made that point earlier, that please always ask for the NTEP approved tests only, because there are many private labs who, for cost reasons, are doing open PCRs and other things. So I think you should just go for the NTEP approved tests. Ask for Gene Expert, ask for TrueNat, and if in the private sector, you can also ask for Expert Ultra.
So I'll put this question straight across to Dr. Kabra. Sir, this TB Sure, and there are many tests which are there available nowadays coming up, which are not WHO approved. So your take on this, sir?
Yeah, I totally agree with Dr. Tanu that there may be multiple tests available with the multiple names, and we should use only those tests which are approved by the NTEP. At the most, we can diverge a little bit to use ultra, but not the other tests.
Thank you, sir. Next question to Dr. Ankit. Sir, IGRA versus MANTU. So how do you, there are some states which are promoting IGRA. There is a question. So how do you weigh MANTU versus IGRA? Can it replace it? Should it replace it? Why it should replace it?
So I think there was a very clear guidance by the WHO and by the National TB Elimination Program that IGRA is technically complex. It is definitely more costly, and it is not a point of care test. So we should not replace MANTU with IGRA. So I think that point was very clear from the programmatic point of view. So you cannot replace a MANTU with an IGRA, right? So I think that has been the take of every one of us, that you cannot replace it. You occasionally can use it in your practice in some circumstances if you're really worried about a latent infection and you want to treat it or you don't want to treat it. So in some circumstances you can use it, but they're definitely more costly, and for the general population you cannot replace it.
One question is regarding the regimes that you have suggested, the 6H, the 3HP, and 1H. Other than these, are there any other regimes available? Especially for the private sector, which one of these is the rifampicin available? I know you have touched on this in your presentation.
So I think very clear. We follow the national guidelines. It is 6H. That is what we follow. I don't think so rifampicin is available with us at the moment in the commercial market. Kabra sir, do you have any clarity on whether it is available in the program?
So as there are 3 regimes, first is 6 months of isoniazid for all age groups, and it's available. Second is 3 months weekly rifampicin isoniazid, and that is after age of 2 years. As of now, the company is not providing it. Central TB division is trying to gets DG permission to get the drugs for only programmatic use. So I don't think it is available commercially, and it will be available commercially. So it is after 2 years of age, and it should be shortly available. Third regime is 3 months of isoniazid and rifampicin. So it is not being recommended as of now uniformly for all, because of the concern regarding if we use rifampicin, then it may produce more of a MDR regimes if they become resistant to it. Though some of the states have used it only in a selected population. So as of now, it is not recommended to use 3HR. And the last one, if it is a isoniazide resistance, then you can use 3 to 4 months of rifampicin daily.
Thank you, sir. Sir, there is a question that AIIMS Delhi is starting adult BCG vaccination. What is the reason behind that?
It is not a service or a clinical care. It is part of a research project, that a multi-site research project to prevent or control tuberculosis. BCG revaccination is being tested, and it is not the service or recommendation. So wait for result of this trial if it is really decreasing the tuberculosis.
So any of these skin tests, CTB tests, anything which is going to be, there are questions about these ones in the chat box.
CYTB or CTB,
Yes.
these are specific skin test, which is in vivo IGRA based test, in which there are specific antigen which is specific for the Mycobacterium tuberculosis. It has been approved for use in children above 18 years, in persons above 18 years of age. There was discussion that whether it can be approved above 5 years of age. Probably it should come very soon that it will be approved. So this is as compared to it. Obviously, it has some advantage as compared to the PST or MANTU test. And if it is available, possibly it may add to the identification of a tuberculosis infection, and may be used as an adjunct for the making the diagnosis of tuberculosis.
Thank you, sir. Dr. Ankit, whether MANTU can differentiate whether it is the positivity is because of vaccination or infection? How do we look at it? Somebody who has had an infection or somebody who has had a vaccination, how to read this MANTU?
So I think, see, you have any MANTU does not distinguish between infection and disease. So that is one thing which we have to understand. You also need to look at symptoms simultaneously, right? So if you're trying to look at only a latent infection versus whether this MANTU is positive because of BCG, then you have to look in terms of the clinical context. If the child is actually exposed to disease, to a household contact, then irrespective of the MANTU, the child requires prophylaxis. But it may be sometimes difficult to distinguish whether the MANTU is positive because of BCG or not. That is sometimes can be difficult. I think IGRA is definitely more useful in such situations.
Thank you. Dr. Tanu Singhal, what is the prognosis in patients of MDR, the patients living with HIV and who have MDR? So there is a comment that very, very harsh comment that they usually either die from drug toxicity or delete. So your take on this?
So I would say that the prognosis of MDR TB is worse than drug sensitive TB, and the prognosis of MDR with TB with HIV is even bad. But currently it's not that bad. I mean, unless the patient comes with very low CD4 counts and you have now good drugs available. So it's not, I don't think you can give up on such a patient. You would have to treat, and currently with the current regimes that we have in MDR TB, at least without HIV, treatment success rates of 80 to 85% have been reported.
So the things are not so bad after all. Thank you. One question again for you: when it comes to abdominal TB, and microbiological diagnosis is not possible at times with all those needles and pricks. So how do you go about treating such patient, and when do you consider MDR in such children where specimen is not available?
So, I mean, unless the patient has any risk factors for MDR TB, you would evaluate these people. You would make sure you're not dealing with inflammatory bowel disease, which is a very close differential of abdominal TB, and then start them on first line treatment. And then, as I said, if after 4 weeks these patients are not improving, then you would either consider the alternative diagnosis like Crohn's, which is a very close mimic of abdominal TB, or drug resistant TB, in which case you would even do an invasive test to make a diagnosis. Like, so if it needs that you do a laparoscopic biopsy of a node or the omentum, you would go ahead and do that before you actually think of switching to an alternate regime.
The point is that even without a microbiological diagnosis, given a particular scenario, there is a place for starting MDR TB treatment or no? That's it.
So that is provided you have made efforts and you have ruled out an alternative diagnosis. I think that is very important.
Yes.
We have seen patients with treated as TB turning out to be lymphoma. We've seen patients with abdominal TB being treated and not getting better and turning out to have Crohn's. So I think you have to be very careful because why? You can start your first line treatment empirically because you have done your gastric lavage and all, it's okay because the drugs are not toxic. But second line drugs are hugely toxic, expensive, not easily available. So you have to be very careful. So if you have made all the efforts and yet you can't reach a diagnosis and you're made sure you're not dealing with an alternative case, then you call that probable MDR TB and you can start treatment in these patients.
Thank you. Now the question for Professor Kabra. Sir, what is the effect of COVID on chest radiology? So post-COVID, are there any the X-rays that you're seeing? Are they any different, or the pulmonary TB is it any different before and after COVID?
So when there was a COVID, there was a lot of problem and confusion regarding what may be the cause of these shadows on X-ray. Though it was not so common for pediatricians, but it was more problematic for the adult physicians and pulmonologists. As far as COVID is concerned, it would be more of a peripheral lesions along with a ground glass appearance. While in TB, it's different, but there may always be overlap of 2-3 things together. And some, though rarely, but many unusual forms of X-ray abnormality has been reported, including some having a nodularity all over, predisposing for the this hematogenous spread and so on. But there is not so much of a confusion about TB and COVID. There may be some overlap of a viral infection and TB.
Thank you so much, sir. I think I will thank all the experts, Professor Kabra, Dr. Tanu Singhal, Dr. Ankit Parak, for all the time they had given. And to the chair for the session, Dr. Kalpanavar, sir. Dr. Jagdish Goel, I think I'll hand over the reins to you. Okay, over to you. Thank you so much. Thank you.
Sir, just a last question, Kabra sir. This question is from Rawat sir. Is Government of India is considering to revise the target of NTB by 2025? This is the last question.
As of now, I have not heard about any meeting conducted for this thing. But obviously, going by the and even the TB report of Government of India is silent on this thing, that how much we have achieved and how we can improve on this thing. There is a use data and reporting at what we have achieved till now, but what are the barriers and how we can improve on it. But I feel that all the stakeholders, including central government as well as pediatricians and TB care providers, will work together, and we may be better off, though we may not be able to achieve the set target by 2025. This is for the government. I hope they'll revise this.
Thank you, sir. So on behalf of IAP National Respiratory Chapter, I would like to thank all faculty member, moderator and attendees. We